people joining us, which is great. And so we will start now and have our discussions and put something together for our plenary. So once again, thank you all for joining us for this sharing and learning event. This event was to have been held last year, but COVID-19 ensured that this couldn't happen. So here we are today, 1 year on. We are here sharing and learning from the CwPAMS project. In Ghana, this project has brought about partnerships across the whole country, from north to south, and from east, but not quite all the way to the west. We had 5 partnerships which undertook various activities, all aimed at controlling the use of antibiotics. All the activities led in some way to the promotion of antimicrobial stewardship. We will hear from these partnerships, learn from their activities, and hopefully identify ways in which we all can promote antimicrobial stewardship. But all of these activities and all that we'll be putting into practice after this meeting must fall within the context of our country mechanism and action plan. It is for this reason that the Ministry of Health, through the National Platform for Antimicrobial Resistance and the AMR Secretariat, has been updated on all the activities taken. And the ministry has been supportive in all the activities of these partnerships. Today, we share with us the perspective of the Ministry of Health with respect to the CwPAMS and how it fits within the national program and plan to fight antimicrobial resistance is the Chief Program Officer for Pharmacy in the Ministry of Health. The AMR Secretariat is under her directorate, and all activities relating to AMR and AMS fall within her purview. She is a pharmacist with over 30 years in the private service, in the public service, from a hospital pharmacist through head of procurement, and is now Chief Program Officer for Pharmacy. Ladies and for pharmacy for the Ministry of Health takeover.
Thank you very much, Yvonne, for that introduction. And thank you very much for organizing important events. Good morning to all. And I'm very happy to be part of this 2-day program. Indeed, the Commonwealth Partnership for Antimicrobial Stewardship fits very well in the Ghana AMR plan. That's our national action plan. We have sought to use health system strengthening strategies to implement various aspects of our NAP in the CwAMR platform. In all our activities, we have sought to use the One Health approach. What this means is that every effort at implementation of our National Action Plan, that's the AMR National Action Plan, seeks to bring together all stakeholders in animal health and the environment. This approach has afforded us an opportunity to work closely with all our relevant stakeholders. We have formed subgroups. For instance, we have an advocacy subgroup, we have a stewardship subgroup, we have a surveillance subgroup, IPC, and on, goes on and on. So the point I'm making is that we have in all our activities so to leverage on collaborative processes. I'm very happy to say that the implementation of the CwPAMS program in Ghana has contributed immensely in our system strengthening approach to implement SNAP. For example, through the program, the various health work very closely together and strengthen their collaboration during the COVID-19 pandemic. They could leverage on this collaboration to improve our IPC systems. Our Pharmacy Council in boosting the CwPAMS projects by giving them CPD points, senior professional programs. So the Pharmacy Council has recognized a forum, a medium through which we can continuously learn, and they have actually awarded some credits to the CwPAMS project. Hello.
Hello, we can hear you now.
Hello. Good morning, all. Am I audible, please?
Yes.
Thank you. I was having
it keeps on breaking.
So good morning, everyone. And I must say, I'm very happy to be part of a very important program about that. I think it's just the internet full manager. Good morning, everyone. I would like to start by saying that I'm very happy to be part of this very important two-day program. Indeed, the Common Stewardship Program fits very well in the Ghana AS to implement National Action Plan. And the CwPAMS project seeks to do the same by sought to use the One Health approach. What this means is that we have strong collaborations among the animal health, the human health, and the environment. This approach has afforded us an opportunity to work closely with sectors.
Hello. Hello, Mrs. Aziz. Please. Okay, so it appears we cannot hear you. And so perhaps when she comes back, we will allow her to make her speech. But before we move forward, we would like to have a volunteer who will assist us with a summary, just about a 2 to 3 minute summary to be presented at the plenary. Can we have a volunteer, please? Hello, please, am I audible?
Okay, I'll volunteer to do that.
Thank you very much, Dr. Ankra. So even though we missed part of Mrs. Aziz's message, those of us who can capture that when we are getting to the end, if she's unable to rejoin, we will put that together as well so that you can capture it. So we will start off with a presentation from the Assemblies of God Hospital and the Norfolk and Suffolk NHS Trust to listen to what they did, some of the challenges they met, their achievements they have chalked, and perhaps the way forward. So if we have a representation from that partnership, we will hear you now. Hello, any representative from Assemblies of God or Norfolk and Suffolk NHS Foundation Trust? Okay, in that case, we will move on to LECMA. We will take our next presentation then.
Okay, thank you very much. Can I share my screen, if you permit me?
I believe Nick will support you in that. Are you able to do that for us, Nick, or should he share his screen?
I'm sharing now,
Yes.
if that's okay. Is that all right? Is that the right slide?
Yes,
that is it. It is.
Yes, even though I will be speaking, yes, my understanding is that I have 10 minutes to do that. And so good morning, everyone. And thank you. My name is Dr. George Amofa, former Deputy Director General Ghana Health Service. And I'm making the presentation on behalf of the project lead, Sam of the UK partner, Professor Afari of School of Public Health and mine, and the other members. The partners, the lead partners were the UK Faculty of Public Health, the Ghana Public Health Association, and LECMA Hospital, Lejokuku Municipal Hospital in Accra. There are quite a number of the partners in UK, but they were all under the UK Faculty of Public Health. In Ghana, the Pharmaceutical Society of the Ghana Pharmacy Council were all part of the project, especially with the advisory committee, the regional health directorate and the municipal health directorate of Lejokuku were all part. The project goal was to establish and evaluate a functional model of antimicrobial stewardship in a facility, bringing all things together and seeing how it will span out. It was a 15-month short-term new partnership project, which started in January of 2019. It was extended to January 2021 because of the COVID period. And then we had another grant just a few months ago to extend it to June 2021. The Ghana Public Health Association basically is a voluntary, political, strictly professional group that's open to all public health practitioners, irrespective of their affiliation, to advance the cause of public health in Ghana. And some of the key achievements that have been achieved were: one, establishment of a functional antimicrobial stewardship advisory committee. We completed basically 2 antimicrobial stewardship global. Yes, we completed 2 global one prevalence survey for the first time in the hospital, and results definitely show that it's possible to conduct such a survey in Ghana and in a hospital. We've established a surveillance system, both laboratory surveillance to monitor antimicrobial prescribing use and resistance in LECMA, and capacity is now built for them to do that on their own. We've done basically completed antimicrobial prescribing data audit on 2 occasions. In fact, the extension have actually added another one, and so basically 3 occasions. The last one was done locally without any support. We've implemented a new delayed backup prescribing at the OPD in the hospital, and an article to that effect has been published, and the ULL is there. We've also designed a simple and accessible local prescribing guidelines, which we have termed the antibiotic adult and antibiotic child, based on the standard treatment protocol. Both of them are 1 pager for prescribers. I mean, to guide them instead of going through the entire STG, which is quite bulky. And we've completed IPC guidelines review based on the WHO infection prevention control and hand hygiene assessment tools, and that basically also guided in the design of the IPC messages in the hospital. Just one slide for the antimicrobial prescribing report. The first one was basically done hurriedly in June 2019. It was repeated in December 2019. And if we look at those bolded in red, percentage of items with indications documented, let's say the diagnosis, the prescription form, it was quite low initially. It actually moved up to almost about 90%. And by the definition, percentage of items prescribed appropriately was definitely also quite high, from 12 to about 90%. The recent one that have been done after the extension show the indications are about the same, roughly 88 plus, but the appropriateness of the prescription has gone down just a little because probably of the COVID and with upper respiratory tract infections and all sorts of things, and so the use of antibiotics to be on the safe side and other things probably has brought it just a little lower, but it's an indication that there's a need to continue making sure that we sustain the gains. Some of the key challenges. One was the disruption of some of the activities due to COVID-19 in 2020. Then, obviously, because it was a new partnership, inadequate funding, and the usual rigid restrictions in expenditure. And because we didn't have enough funding, absence of an administrator on the ground also challenge. Plans for the future. We want to consolidate gains that have been chalked by the project. I must confess that there are quite a lot of things that have been done. Because of the time, I won't go into that. But I want to consolidate the gains. Seek additional funding opportunities to expand the scope of the initial project and actually institutionalize it in the hospital. That is the word, institutionalization, not just once-off things when you have funding. And then contribute to antimicrobial stewardship by sharing information, as we are doing now, on achievements with national and international bodies that have been done, and we continue doing that, and publish in peer-reviewed journals. That also has been done. Well, what have been our contribution to the NAP? One is definitely optimizing of therapy for individual patients. Using the antibiotic adult, antibiotic child guideline for prescribers at the OPD, and even in the ward. then preventing the overuse or misuse of antibiotics because of the auditing system we've introduced there. I mean, which first line drug to use for which particular antibiotic, and then if you are moving to second line and then third or restricted, then there has to be a system for approval by somebody else in order to do that. And your attention can be drawn gently by the pharmacist or somebody else that this needs to be sorted out without any confrontation. Then the last one was overall minimize the development of resistance at the level of the individual patient and community. The data showed recently that there's quite a lot of resistance to some of the commonly used antibiotics, and that is part of the what we've been able to achieve so far. Thank you. Over.
Thank you so much, Dr. Amufa. You really did keep to time, and for that we are very grateful. Please, if you have any questions for any of the presenters while they are speaking, do go ahead and put it in the chat box, or you can send it to me directly. But I think in the chat box will allow them to see it and prepare to answer them. But Dr. Amufa, I have two questions for you with respect to your partnership. Would you say that your achievements so far are now a part of the life and practice? There is significantly quite some work to do for us to get there. So that's my first question. And then my second one is, what particular challenge do you think should be tackled immediately to ensure the effective scale-up of this project? What particular challenge do you think should be tackled immediately to ensure effective scale-up of the project? If you can just address those for me, thank you.
Thank you very much. And if I got your first question correctly, whether the partnership is solid now in course, maybe because it's a Ghanaian partnership plus UK partnership. Yeah, that we've made very much progress. I mean, we are almost in touch with each other by email, by WhatsApp, and even soliciting for the various other things apart from what we are currently doing. And so that is definitely very reasonable. We are quite free with each other outside the project, and so that is helping. The problem is that if you are dealing with somebody not in Ghana, in course, I mean, where you can even walk to the person, that is a challenge. I mean, and UK systems are definitely not the same. The UK have been hit quite severely by the COVID, and quite a number of them are also engaged in that. And so that is a key challenge. But coming to the challenge, there is basically inadequate funding to institutionalize the things we have talked about and expand beyond the hospital to the community, because that is definitely our vision. We want to make sure that we are able to engage the surrounding pharmacies, then the community, the larger community, and other things. And that definitely needs more funding, both locally and outside than we currently have. Remember, ours was only a small grant because it was a new partnership. I think we have matured to be classified as a sustained partnership. Thank you, and over.
Thank you so much, Dr. Amufa. Funding, and I'm glad you mentioned both local and international. I am sure that those of us here will be able to support, particularly maybe with raising funds locally. Internationally, we can look to that, but we know that COVID has had a lot of negative impact on finances across the globe. So we wish you all the best. But before you go,
there's a question from Xavier.
Xavier, you have a question. Do you want to? Yes, this project at the facility after the it is still an issue of funding, but if you can just go ahead and address that.
No, it's not only for funding. I mean, you said I should mention one. And so
okay.
One obvious.
Please go ahead. Sustainability.
But I can tell you that in terms of sustainability, the sustainability is equipping people to be able to perform. I mean, and the tools are there now in terms of the guideline for prescription. In fact, the joint ward rounds by the AMS team with all stakeholders on a reasonable constant rate, and the capacity for them to do let's say antimicrobial auditing at the OPD. But that has been done. The last one was done by staff at LECMA. I mean, without any, and they can do the delayed prescription system on their own because they have the capacity to do that. And so that capacity that has been built is definitely even more than the funding. Some of them will definitely depend on additional funding if you are extending it to the community and others. But yes, and so I think I'm greatly impressed with progress so far.
Thank you so much. We do have another question, but I would like you to jot it down until when we get to the main discussion time. And that is from Vicky, who wants to find out which particular, if you can identify the particular aspects of the project that did not have sufficient funding, and where you suggest the funding resource. Where do you suggest more funding resources made available? So it's very linked. Which aspects didn't get sufficient funding, and which aspects do you think should be funded, should have more funding, perhaps going into the future? So if you can just capture that, and then when we get to the general discussions, you respond to that, that would be great. So we will go back to our presentation from Norfolk and Suffolk, and this presentation will be made by not somebody from the partnership in Ghana, but it will be made by Sarah Kavanaugh, who is the International Partnerships Lead for CPA. So Sarah, if you are with us, please take over.
Hello, can you hear me, Yvonne?
Yes.
Hello, thank you so much, everybody. Just double checking, there's nobody who's been able to join from CwPAMS or NSFT. I think they had some technical difficulties. So I'm very happy to speak to this partnership because I think the successes have been many, and it's really important that we recognise them. I believe there's one slide, Yvonne, if you could move on to the slide. Perfect. So as Yvonne said, my name is Sarah Kavanaugh. I'm actually part of the CwPAMS leadership team, but I have had I've had quite a bit to do with all the partnerships, but this partnership is quite close to my heart, partly because I'm actually employed by the Norfolk and Suffolk Foundation Trust, although I wasn't when the project started. And previously, a number of decades ago, I was lucky enough to live and work in Northern Region in Ghana. And actually, I do notice Suzanne Thomas is also in this group as well. So hi, Suzanne, she came to visit. So just talking about this programme, it's the smallest of all the 12 partnerships. And and it's also in a rural setting. But these two similarities, both between the Norfolk partnership, but between Norfolk and CwPAMS, were sort of not lost on it. A large rural geography, challenges that are actually quite different to the rest of the country, whether that country is Ghana or England. So I think there was an awful lot of learning based on the fact that there were many similarities between these two hospitals and these two health facilities. So just starting off with the successes of this partnership, as I said, there were many, and apologies if I don't get them in the right order. The education capacity of this partnership was huge. And the thing that I think worked really well was the education of the community. So it wasn't just the health workers at the CwPAMS Hospital, the Assemblies of God Hospital, that were educated in stewardship, and also in infection prevention and control, but also the fact that this reached out into the communities. And they did this in a number of really quite innovative ways, with broadcasts on local radio stations in CwPAMS, which was just fantastic, but also community events, community Durbar events, where many members of the community came, big loudspeakers, songs were commissioned, dancing. You had people in the community who'd come together, but with people they trusted to give them accurate, correct information and try and, I guess, dispel some misinformation that can be the case with antimicrobial stewardship. And then also going forward into the pandemic, because the trust was there, if you like, people, I think from what I've heard from meetings I've attended, members of the community and other health professionals were more likely to trust the health professionals who were giving them the information, which actually really helped this hospital respond to COVID. Another challenge, which the CwPAMS team haven't actually put on this slide, but I'm going to mention anyway, is there were benefits, particularly in the last year, that came back to England, to the Norfolk and Suffolk partnership, learning from this partnership as well. At the point that we were in the thick of things last March, fortunately, CwPAMS didn't have cases, but actually as the situation changed, we were able to learn from partners about how this was addressed, how you got people to hear the messages, difficult to reach groups, because we have these challenges across the geography, across Norfolk and Suffolk as well. So the continued public engagement, I think, it has been really key to the success of this partnership, and also the sharing of guidelines, prescribing antibiotics appropriately, handy charts, and so on, so that the people in the hospital know what it is they need at the point of the prescribing. So moving on to the challenges, and this is a continuing challenge. I think it's getting people access antimicrobials in various ways, and particularly in a rural setting. It's quite common that they are obtained from markets or various other people. So actually ensuring that people are educated, but also this partnership worked in collaboration with the chemist shops and the other drug sellers, and explaining what was needed really to best inform patients. And finally, before we go and see if there are any questions, I think with the COVID response in particular, it's really important to say that, as other partnerships had done as well, although many of the activities had to be curtailed, travel, for example, wasn't going to be possible, but actually meetings continued between both sides of this partnership. And it was a real support for each other. And one thing that came out of one meeting I was fortunate enough to attend was there was a real discussion around the mental health of health workers, both in this region of Ghana, but also the difficulties that were being experienced by health workers in the United Kingdom. And actually, there was quite a lot of learning for that. And because Norfolk and Suffolk Foundation Trust is a mental health trust, there was quite a lot of learning that went both ways. And I think it's really important for everybody to realise as we're coming out, hopefully, of the pandemic or starting to, there's going to be a bit of sort of collateral damage for that. And this partnership had already started considering that and supporting each other. So I'm sorry, CwPAMS were not able to join today, and I'm sure I didn't say half the things that they would have done, but it's a real privilege to be able to see this partnership, how far it's come, and I would be very happy to try and answer any questions. Otherwise, I'm sure I can come back to you when I've managed to speak to somebody from the partnerships. Thank you very much.
Thank you so much, Sarah. And yes, one of my questions actually, which I do not know if you are in the position to answer, but it has to do with the issue of itinerant drug peddlers and other facilities from which these antibiotics can be had. I think that it was right at the beginning of the project that Saboba had this issue, and I think once they started with the education, there were some instances where some of the people were even threatened. And
I don't know if the sound stopped.
So we had to organize a stakeholder engagement and actually handled the problem quite a bit, but I think that perhaps there is more work to be done. And so they think, what are some of the ways in which we could support, even as PSGH, because this is our final meeting for the project. So if there were some ways in which we could support, I do not know.
So shall I try and come in on that one, Yvonne?
Yes, please.
Okay, yeah. So I obviously don't have all the answers. I haven't been in every single meeting, but my understanding from being peripherally involved with the project and also looking at the reports that obviously came back into FET and CPA is, yes, you're right. At the beginning of the project, there were some challenges around people obtaining their medicines from the drugstores at the market and so forth. But I think a key success of this partnership has been their community engagement and their communication. You're not going to change every market seller overnight, and going in heavy-handedly isn't going to work. So what this partnership did was that they had meetings. They actually held meetings with the people that they were trying to influence, and they've continued to do that. And I think these community events as well, they just helped the community come together. It is quite a big challenge, not just in rural parts of Ghana, but across many of our partnerships. But I think the key to success, or the key to starting to move this in the right direction, is open and honest communication, and that's something this partnership did really well, and I really commend them for it. Yeah, many challenges, but the successes, I think, will be long lasting, and the partnership as well. I know we're coming to the end of the program, but I think the relationship between these two hospitals, these two health facilities, will be long standing. Thank you,
Sarah. Yes, I must say that I also believe that the partnership, the achievements will be long-standing, and I am sure that we will come up with ways in which to handle some of the challenges to ensure that there are greater strides are made in the future. So thank you very much for stepping in for this presentation. And so
it's my pleasure.
believe we
Thank
can
you.
now go on to our third presentation. Thank you. Nick, can you help us with that? And that presentation, I believe, will be from the whole teaching hospital. Is it Kolebu instead? Okay, so that will be from Kolebu Teaching Hospital and North Middlesex University Hospital Trust. So if we have a representative, please go ahead and take over.
Thank you very much. I'm presenting for Kolebu Teaching Hospital. My name is Daniel Ankra, I'm the Director of Pharmacy. Next slide, please. Next slide. Right, so this was a partnership of all the people, all the organizations involved, and it was a very good partnership because support was there for us to work. Next slide. So the title of our program was basically to build professional capacity and sustainability to deliver effective antimicrobial stewardship and IPC programs in Accra, Ghana, but specifically at the Kolebu Teaching Hospital. So the lead partners were from UK and Ghana. For the UK, we have Dr. Mariam Fendereski, and I happen to be the lead for the Ghana partnership. Next slide. So you see here my members with the third reps, Will and Chloe. Next slide. Now, these are my members who are ready for action, both the Kolebu and the North Middlesex team together for a PPS survey. Next slide. So the key achievements, the first one was that through this support and partnership, the Kolebu Teaching Hospital, which is a 2,000-bed capacity hospital, had an opportunity to conduct the first comprehensive point prevalence survey. Hitherto, we've only had surveys on one ward or one department or things like that. But for the first time, we had the opportunity through this partnership to survey the whole hospital, a 2,000-bed facility. All clinical departments, all units were surveyed. This led to a solid baseline information for the hospital that will be a benchmark for future studies. Next slide. We also had opportunity to train pharmacists on how to collect PPS data. So now we are like a point that can be approached to train the trainer of trainees on this issue because we've had in-depth training. And then further, there was a 3-day introductory training as an antimicrobial pharmacist. In fact, we did this for all the referral hospitals in the Greater Accra region. There are, they are Kolebu Teaching Hospital, Reach Hospital, 37 Military Hospital, Police Hospital. So pharmacists were selected from these facilities and they were trained on antimicrobial stewardship. The idea is to have pharmacy antimicrobial people as leads in the area of antimicrobial stewardship so that the work can go on. Next slide. We also had the opportunity to train various health workers on infection prevention and control with a focus on the WHO's 5 movements for hand hygiene. This was just before the COVID outbreak. So it was something that came in at the right time. we also had the opportunity to train outpatients. And this was particularly on the World Antimicrobial Day. So we engaged outpatients and gave them information on antimicrobial stewardships. And this we do periodically just to ensure that they stick to the right activities. Next slide. So mistakes are inevitable, but giving up is unforgivable. I'm talking about challenges. So next slide. So for our challenges, at the time of our PPS survey, we were not using electronic medical records. So collecting data was a bit of an issue because we had to extract these from folders. But with the help of other colleagues, we were able to circumvent this and had a very good work done. Next slide. One of our aims was to optimize antimicrobial prescribing while focusing on surgical prophylaxis. But this was not fully achieved because of the effect of COVID-19, which adversely affected our partnership. In fact, our partners, that is the North Middlesex University Hospital, they happen to be the main infectious disease center in London. And they were really overwhelmed by COVID to the extent that most of their, or some of their staff were affected. So there was like a break in our activity, and a few of the things we wanted to do, we could not do. Next slide. So we were unable to fully disseminate our findings on the PPS to all the workers. Now, this is a very important thing because it is your findings that will change their habits. But if you are not fully able to disseminate this information, then there will be a break. But we are gradually picking up and we are trying to mop up so that they will get the full effect of it. Next slide. So our future plans are to train at least one pharmacist in our hospital as a fully fledged antimicrobial pharmacist to champion antimicrobial, working hand in hand with other healthcare professionals. And then we want to inculcate PPS into the program of work in our hospital so that there will be continuity. We can't always rely on funding from outside. Once we take this as part of our program, we'll budget for it and try and do things on our own. Next slide. Our contribution to NOP, there's a baseline antimicrobial information available. Now we have this. And so we can always do future studies using this as our benchmark. This is something that the National Action Plan is asking for, that we keep on doing this to sustain the pressure on antimicrobial issues. Healthcare workers were trained in good IPC, and they will continue to impart knowledge. We also train pharmacists from other health institutions, and the idea here is for them to also start things at their facilities and improve the effect of the National Action Plan. So we want to uphold this and keep it going. Next slide. Recommendations for MOH. Now, for about a year now, or almost a year, sentinel sites have been formed, and this is one of the requirements of the NAP, but they are yet to start functioning properly because they've not been resourced. We would want this to be done so that antimicrobial resistance and antimicrobial use surveillance will be done effectively. We also believe that there are a few items in the National Action Plan which have not been fully implemented, like training for DTCs and all that. We haven't really had a feel of it. We hope that these things will be done so that the full effect of the NAP will be felt. Next slide. So on that note, I acknowledge the CEO of my hospital and the CEO of North Middlesex for supporting our cause. I appreciate all officials of the community hospital who assisted in diverse ways to ensure success of our program. We thank CwPAMS, third CPA and the ODA and Fleming Fund for their unflinching support. We also thank all those who helped in their data collection activities. Finally, we are grateful to the Pharmaceutical Society of Ghana for supporting us anytime we call on them. Thank you very much.
Thank you so much, Dr. Ankra. And we can see that quite a bit took place during this project. And once again, let me remind all participants, if you have any questions for any of the speakers, just drop it in the chat or raise your hand. I don't say Via has a question to ask the first time when you raised your hand that it hasn't gone down. And then after that, I'll allow you to ask your Xavier.
Xavier's hand has been up
so
for more
how
than
2 questions is from my end. Say that the project work. Okay. So how would you say, you did mention going on ward rounds and all that, but apart from that, how else would you say perhaps maybe some unintended consequence of that project? And then how do you mention that in the past you did it at the World Antibiotic Awareness Week? Do you intend to do it on maybe on a more regular basis, or do you think it will be better to wait until that time when we are creating awareness to use to leverage on that? So these are my 2 questions.
And please,
thank you.
During your first question, there was a lot of breakages in communication. So could you repeat the first question? Hello?
I was asking how you think the project has affected. Dr. Ankra, I was asking how you think the project has affected work with other healthcare professionals. So how you interact with other healthcare professional projects. So in other activities, how pharmacists and other healthcare professionals relate in patient care, in other activities, not that.
Right. Thank you very much. In fact, because it was a comprehensive thing, now everybody is aware of the role of the pharmacist, first of all, and everybody is prepared to work hand in hand so that at the end of the day, the patients are those who will benefit. Now, secondly, with the engagement with the community, it's not a one-off thing. After the World Antimicrobial Day, we continue to do it periodically so that we'll maintain the pressure and make sure that they don't go back doing the old things that they were doing. So that was when we started us at the World Antimicrobial Day, but we continue to do it periodically. Thank you.
Thank you very much. Please, do we have any other questions for Dr. Ankra? Otherwise, we will say thank you. I do not see any questions in the chat box. And so we will say thank you to you and move on to our next presentation, which Nick, you will help us with. And that has to, that will be from Ho Teaching Hospital or University of Health and Allied Sciences. Please go ahead and take over.
Thank you, Yvonne. I'm presenting on behalf of the partnership. My name's Yogini Jani. I'm the Clinical Safety Lead for Digital Healthcare at University College Hospitals in London. If I can have the next slide, please. my hospital was the lead UK partner for this partnership, and we partnered with our colleagues at Ho Teaching Hospital and Dr. Cornelius Dodu at University of Health and Allied Sciences. Cornelius is also on the call and may step in as required during the presentation. If I can have the next slide, please. The aim of our partnership was to enhance hospital pharmacists' roles to support the delivery of antimicrobial stewardship programs in Ho Teaching Hospital. And we aim to do this by improving knowledge, awareness, and practices around AMS, or antimicrobial stewardship. We also wanted to support the development of an overarching local antibiotic policy using a multidisciplinary approach, and improve the documentation of antimicrobial use locally so that it would enable surveillance and research through academic partnerships and collaborations. And we also applied quality improvement approaches in order to improve the documentation. Finally, and uniquely, I believe, we wanted to empower our pharmacists to be able to communicate effectively with persons with hearing and speech impairment. Next slide, please. So our three key achievements have been that we have successfully completed 3 antimicrobial stewardship global point prevalence surveys, the third of which was done recently during an extension of the funding. This has provided us patterns of use across seasons in terms of the antibiotic use, and we've been able to publish the findings from the first 2 surveys in the journal Antibiotics. This has also given us some early indications of potential impact of increased antimicrobial stewardship awareness. The partnership has resulted in successfully establishing an antimicrobial stewardship committee, which has full board support. The CEO at Ho Teaching Hospital was completely behind the initiative and has endorsed the committee and the need for the committee. And excitingly for us, the AMS committee is chaired by a pharmacist, which helps in our aim, or if you like, a success for our aim that we have empowered and enhanced the role of pharmacists. And finally, through the extension in the partnership work, we were able to address a need that was identified by the AMS committee and the AMS team, which was the need for leadership development for them to fulfill their role more effectively. So a leadership development course and support was provided in order to do that, and that was this year. If I can have the next slide, please. So what have been the biggest challenges? I think very early on in the partnership, and this is a new partnership for us, it was navigating the approvals processes, not just contractually between the countries, but also thinking about some of the financial challenges, due diligence required, and also ethical approval for the work that we were conducting. The second challenge has been that although we did successfully deliver a program of work on sign language communication, we've recognized that sustaining this will be a challenge. There is definitely increased awareness around this, but unless we provide continuous refreshers and training, this is not something that's easy to sustain. It's very much a case of if you don't use these skills, then you won't remember them. So practice is really important here. There is an expert in the organization who leads on sign language, and the pharmacy team can contact the expert and intend to pursue that further. And the third challenge has been obviously the pandemic. So the UK partners had a trip to Ghana for the final part of the work in January 2020. And shortly after that, obviously the pandemic was declared and lots of areas went into lockdown. But the time of that January training in some way did help, because that was the phase in which the infection prevention control training and refreshers took place. And that meant that the Ghanaian team had a refresher in a timely manner to address and manage infection practices during COVID-19. The other challenge has been implementation of the AMS policy because of the timing coinciding with the pandemic. So the committee was established, and I noticed that there's a question in the chat about which committee in the hospital is supporting the implementation of AMS. It's actually a new committee that has been established. It's an antimicrobial stewardship committee. It links very closely to the Drugs and Therapeutics Committee, but because it is a new policy, it will require the time to publicize that within the hospital and embed it. And the policy implementation is part of the work of that committee, which was delayed due to COVID-19. Next slide, please. How has our partnership and the timing of the partnership contributed to the National Action Plan and the recommendations? We found this rather nice visual from a publication from Ghanaian colleagues, and we feel that our partnership has contributed into the implementation phases and the ongoing monitoring and evaluation phases. So the training that we were able to conduct, the formation of the Antimicrobial Stewardship Committee, fully align with the implementation of national action plans, but require local ownership and further action at local levels. So the timing was spot on. Being able to conduct the global point prevalence survey has almost started and led the way, as colleagues were saying. It's provided the tools to enable ongoing monitoring and evaluation, and the draft local antimicrobial policy will provide the framework to maintain that on an ongoing and a long-term basis. We would also echo some of the comments that were being made by our by the CwPAMS team, which is that it's great that there is now a national action plan, but it's important that local organisations have the support and are empowered to be able to take this forward locally in a meaningful way. Next slide, please. So I will just run through some plans for what's happening on in terms of continuing this work. At an organisational level, Ho Teaching Hospital is seeking to embed the Antimicrobial Stewardship Committee within its infrastructure so that it's recognised on par with other committees. The UHAS team, so the University of Health and Allied Sciences and the Ho Teaching Hospital, continue to build on and consolidate their pre-existing academic and clinical partnership. That was already in place, but the CwPAMS partnership almost provided a focal point to be able to develop those relationships further. At an international level, we continue to work together to explore funding opportunities to strengthen our collaboration. Unfortunately, because of the pandemic, we did hit a slight, I wouldn't say pause, but there was a lull in activity in terms of partnership development internationally, because each of the partnership groups was seeking to address things locally, but that's sort of reinvigorated again this year with the extension and so forth. Finally, on my final slide, I'd just like to really emphasize and reiterate that it was a partnership between two academic and teaching hospital organizations, one in Ghana and one in the UK. But everything that we've achieved, including some of the challenges that we've faced and addressed, has been the result of a teamwork. And this picture is of the team that was involved in the data collection of the global point prevalence surveys, and in involving the team, which were members of the hospital as well as academic members, what this has really done is established and raised the awareness of antimicrobial stewardship as an important issue. And some of our members were, during the time that we were there, raising these issues on local media through local television and radio outputs as well. So we feel that we've achieved an incredible amount during the partnership across very challenging times. Thank you. If there are questions between Cornelius and I, we will aim to address them. Thank you.
Thank you so much, Yogini, for a great presentation on what has happened with your partnership. I think one interesting thing, I have always talked about this particular aspect of your partnership is the communication with respect to speech impairment. And I don't know if it is possible to comment on that further and perhaps tell us a bit about how it is being incorporated effectively into the system, because I believe I may have missed it, but I heard you say that there is a specialist there who supports. Is it possible to look at perhaps training so that more people acquire some basic skills of communicating, and then it becomes perhaps one of the things that you take with you once you have worked in that facility for a while? And also, are there any plans to bring AMS back high on the radar? I believe this morning that was one of the things that we talked about at the plenary, that it is COVID has pushed everything to the back burner, and really AMR has always been the silent pandemic. Are there any ideas of how we can perhaps bring it back onto the front burner in the facility? Thank you.
Thanks, Yvonne. I see Cornelius is on screen, so I'll hand over to Cornelius.
All right, thank you very much. In terms of the sign language training, we had an expert coming to train the pharmacist, mainly because it's more like the last port of call that clients tend to encounter before they leave the facility. And I mean, if all the treatment has been given and the individual with the challenge doesn't know how to take the medicines, there is a major challenge there. So, the pharmacists were given certain, basic sign language skills. But then there is an expert in the pharmacy department, that has got the skills to interact with such individuals. In terms of what we are doing moving forward, we've got the AMS committee that has been empowered such that they were trained as well to conduct periodic point prevalence surveys. So, I mean, these are going to be continued. And then, we tend to get information on the use of antimicrobials, and they are championing a number of stewardship activities in the hospital, so that we're hoping that the committee will champion that course in the hospital. Hello.
So much. Thank you very much, Cornelius. And I see that there is a lot of interaction also in the chat. Continue our engagement in the chat box. The question that was there, I believe, has been answered. It was with respect to the institution of a committee specifically for AMS, and I believe there are quite a number of comments that have come up with that. So I suppose that if these questions, if Xavier, you still have comments on that, when we get to the general discussion, you can bring it up again and we will deal with it at that point. So right now, what I will do is to say thank you to this partnership as well for a brilliant job done, great work in presenting to us what has been done so far, until we get to the general discussion where you may have other questions to address. Thank you. So we will now move on to our next presentation, which is from Police Hospital and Keta Municipal Hospital. So yes, thank you very much. If we have a representative for this partnership, please go ahead and take over.
Hello, Yvonne. This is Jacqueline Snedden from Healthcare Improvement Scotland. Nice to meet you again. So I've agreed to present on behalf of this partnership, which was a new partnership, and we were connected. I work for an NHS organisation. We were connected through colleagues at the University of Strathclyde who had already done some research with the lead partners in both these hospitals. And I'm glad to see that Israel Sefa, the lead partner from CETA, is on the call today. The other lead partner, Daniel Lafrey, is from the police hospital, and both these lead partners are the lead pharmacists within these hospitals. Both are fairly small hospitals. The police hospital in Ghana is, the staff there are largely police officers, so quite different to anything we have in the UK. And Kita Hospital is in a rural area, both hospitals around 100 beds. Next slide, please. So within this project, we were fortunate to be offered the services of the Change Exchange, which are a team of health psychologists based at the University of Manchester, and their area of expertise is in behaviour change. So they joined us for this project. The team from my own organisation, the NHS in Scotland, there was 10 of us, and we were a multi-professional team. So we had 6 pharmacists, we had 2 antimicrobial nurses, and we had 2 infectious diseases doctors. So we were trying to promote a multi-professional approach to stewardship. And I've not detailed the aim here, but our aim really was to try and replicate the model that we have for stewardship in Scotland in these hospitals in Ghana. So we have in Scotland been involved with stewardship for many years. Our programme started back in 2008, and we have a national programme that works closely with hospitals across the country. And we have 3 strands of stewardship. So we have information, which is all about data, surveillance data, audit data. We have education for staff and for the public. And then we have quality improvement, which incorporates guidelines and improvement interventions. So in terms of our achievements, the stewardship team in the hospital is now well established. Prior to our first fact-finding visit, which was back in May of 2019, both Daniel and Israel had put things in motion to set up a stewardship team that was a subgroup of the Drug and Therapeutics Committee. And this was fully supported by management, and at all our visits we have met with the management and updated them on progress. So there was very good support there. So the team's established, they meet regularly, they've got minutes and they've got actions that they're working on. Training was a big part of our project. So on our main visit to Ghana, the whole team from the UK travelled there, and we split into 2 groups, one group going to the police hospital and one to CETA Hospital. And over the course of 2 days, we developed a comprehensive programme of training in antimicrobial stewardship. And through the input of our health psychology partners, we were able to include within that skills practice. So we got the staff who were medical, pharmacy and nursing, we got them working in groups, practicing conversations that they might have about antibiotic use, and really trying to empower all staff to get involved with stewardship and to feel comfortable in querying any prescriptions that they felt were not compliant with the guidelines. We've got several stewardship activities that have been established. So at the very first fact-finding visit, we supported the Ghana team and trained them in how to do a point prevalence survey. And that was our first global point prevalence survey that we did then. On our next visit, again, they had got some data and we helped them to review the data before entering it into the global PPS. And again, we used a team approach there. So we had nurses, doctors and pharmacists collecting the data. One of the things we identified was that it was sometimes difficult to access the guidelines. So as well as the CPA app, which was developed, we also helped to develop guideline posters specific to certain specialties. And at our final visit, which was in February 2020, we took laminated colour copies of these posters out. Coming to the challenges, so the initial challenge really was the UK team becoming familiar with practice and culture in Ghana. Most of us had never been to an African country, had no idea what to expect there. In actual fact, we found practice was very similar to what it's like in Scotland in terms of what clinicians do on the ground. Some things were different, but largely around infrastructure and IT. But in terms of clinical practice, there was not really much difference. And we actually found that some of the practice in Ghana was better than we're seeing in Scotland in some areas. Virtual collaboration can be difficult. Sometimes we can't have good signal, but we established early on in the project that using email and using WhatsApp calls in small groups was the best way for this. COVID-19 has impacted on the final stages of the project. We did have a plan to be doing point prevalence surveys every 6 months, and that has not gone as planned. However, we have managed to carry on with cascading the training, and Daniel and Israel and their stewardship teams have trained staff within the hospital during that time. So we now think that all staff have had the training on stewardship. Next slide, please. So plans for the future, I think we need to maintain the stewardship teams, and I'm confident that will happen, and the activities that we've set in place. Both hospitals have been very active in around audit and have focused in on areas that they wanted to improve based on what was found in the point prevalence survey. We've just started some additional work on dental stewardship. So we had looked at data from the dental departments in the hospitals and found that there was high rates of antibiotic use. So we're working with colleagues in the Change Exchange and also from the University of Ghana to look at this, looking at behaviours around dental prescribing initially in the hospital, and then hopefully go on and do that out in the community. I think it's important to utilise the training expertise that Daniel and Israel and their teams now have, and also the resources that have been collated by the Commonwealth Pharmacists Association, and these can be used to spread the training at regional level and perhaps via the university. In terms of contributing to the NAP and recommendations, I think the ambitions have been established within the partner hospitals, and there's definitely potential to replicate and spread the model that we've developed there. In terms of the standard treatment guidelines, I think reviewing these and updating them to incorporate the findings from the point prevalence surveys that have been done in all the hospitals, primarily around gaps in the guidelines where there isn't a guideline for certain indications, would be really helpful. And then finally, I think it's been mentioned already as part of the Fleming Fund work, I think investment in IT and diagnostics would reduce the resource requirement for point prevalence surveys and audits, because these, as others on the call will know, are very time consuming. And if we had the data electronically, it would make it much quicker to do and take up much less staff time. And I think by doing that, it would also support greater use of access antibiotics, because we would have better data around antibiotic use, but also around resistance, which would mean that the use of more broad spectrum agents could be cut back, because we would know exactly which organisms we were dealing with. So that's all from me. And happy to answer any questions that anyone might have. Thank you.
Thank you so much, I am not sure whether it was from my end or from yours, because there were some parts where I couldn't hear you clearly, but I believe we got, we understood what you were presenting. We all got a gist of what it was about. And yes, great work done with these two facilities. You did mention something about a dental stewardship. I didn't quite get what that one covered. If it is possible for you to comment on that, and also maybe comment on how, a bit more on how COVID-19 has affected some activities, and perhaps in the circumstances, how some of those activities could be revived to ensure sustainability. But before you come in again, perhaps I can also ask that, please, if you have any questions, do put them in the chat box. So please, Jacqueline, go ahead.
Yes, so the dental stewardship work. So both hospitals have been doing audits, and they had found that there was high use of antibiotics in the dental outpatient departments. And so we wanted to explore that. So we're working with health psychologists from Manchester and from University of Ghana, and with a dental researcher. So what we want to do is to interview dental staff around their behaviours in using antibiotics within the hospital setting. And then once we've done that, we would hope to go on and explore how people in the community manage dental infections. And that would be, we think, through interviewing community pharmacists who may be dealing with patients that present to them with dental pain. The second question around how will we recover from COVID with some of the activities. So the small scale audit work has carried on in the hospitals, but what hasn't happened is a third PPS. So I think the plan is to resurrect that, and still to go back to our original thought that perhaps a 6-monthly point prevalence survey would be helpful. So that's probably the key thing that's not been done that we hoped would be, but we hope that that will start soon. And perhaps Israel might want to come in and comment more about that.
Thank you. Israel, do you want to comment? I think the dental stewardship bit is quite interesting. It's very interesting, and I'm sure you will come up with quite interesting results on how community members will deal with dental issues. Yeah, I look forward to reading more about that. Israel, do you have some comments to make?
Hello, Yvonne.
Yes, please go ahead.
Yeah, thank you very much. I think Jackie has well captured everything that we have done so far and what we intend to do in the future with the dental antimicrobial stewardship. And so I think I'm okay with what she has presented so far, unless there are any other further questions. Thank you.
Great. And it shows that forever, or at least being long term, has really taken root in at least in this particular instance. So very, very good news to hear. Dr. Young is from Saboba, and I believe that she has finally been able to join. And so I will ask her to speak maybe just a minute. I am sure she'll be able to manage that for us, just to tell us something, maybe one particular achievement that she is very proud of in Saboba. Dr. Young, please go ahead.
Okay, can you hear me?
Yes, we can, Jean.
Yes.
Okay.
Yes,
I'm sorry because somehow I didn't understand we needed a PowerPoint on this, but all right. We've had some major challenges in Saboba, mostly because we had, of course, we had COVID, we had a number of things going on. All right, let's look at our achievements first. Our achievements, we succeeded in conducting a total over the course of the partnership. We succeeded in conducting a total of 20 community Durbers, informational meetings, 10 in November 2019, 10 in May 2021, and we got wonderful community response. People were really thrilled that we went out. They had great questions. Okay, and we succeeded in conducting week-long 2-hour radio programs on both of our FM stations in November of 2019, and that reached listeners in a 120-kilometer radius, including people over in Togo. We trained most of our staff in antimicrobial stewardship. We also trained infection and prevention and control best practices for COVID. And we've had several COVID trainings more recently. Okay, our challenges, our big challenge with public education, of course, first of all, COVID, it was difficult to have community meetings. Second problem was that we were gearing up to do more week-long radio presentations. And on the 30th of April, our biggest FM station burned to the ground. And about 3 days later, the other FM station was struck by lightning and was off the air. And that second FM station is only just now back on the air. So in the absence of our FM stations, we went ahead and we had more community Durbers. But honestly, I think the community Durbers are a very good thing, because it's good to have people calling in, but when you see people face to face, you get questions that I don't believe you would get if you were on the air. Okay, now our challenges, including in addition to the FM station problem, is we have a variety of people who are all handling or mishandling drugs in our area, and they are making huge amounts of money out of this. And unfortunately, when somebody's making money, they really, their conscience and their desire for money do not always equal each other. We have itinerant drug peddlers who are going from village to village on motorcycles, and they have pushed ciprofloxacin into the point that there are many places if we see somebody coming in from a place where I know they probably have abused Cipro, I don't even use Cipro anymore for typhoid because it's not going to work. We have weak drugs, fake drugs, all kinds of things. Our second problem is the community health promotion zones, which as idealized, these were supposed to be places where very basic things happen in the community, and then anybody who was really, really sick got sent on to a health center or to a hospital. Unfortunately, that is not what's going on. What's going on is a lot of times the nurses who are manning these places are buying their own drugs, including injections, and sometimes including drips, and doing all kinds of quack doctor stuff out in the periphery. And there's no way of monitoring this situation because many of these places are pretty remote. So that's the problem. And again, when they're making money out of it, it's very, very difficult to police. Formerly, the body tended to be a little bit conservative, and they tried to make sure that they did not issue too many licenses or issue them indiscriminately. Unfortunately, the situation there appears to have changed. And now I'm told that if you come with the right amount of money, you can get the chemist shop license. And all of a sudden in Saboba, instead of about maybe 5 or 6 major chemist shops and the health center, Saboba Health Center and the hospital, we might have as many as 15 or 20 chemist shops in Saboba. The situation has actually gotten so bad that one of the long established chemist shop owners was complaining to me bitterly several months ago that he could no longer make a living from his chemist shop. And this is a man who's been running that shop for probably 15 or 20 years and stocks quality drugs. And of course, one of the problems is we don't know where some of these people are buying their drugs. We don't know how good they are. Our challenge at the hospital is that the health insurance, National Health Insurance Scheme is still not paying as it should be. And so many times we're having to write prescriptions and send people to town, which means the quality of the drugs that they're getting when they go to town are questionable sometimes. So those are some of the challenges that we have faced and are facing. You know, we're trying to address these things. We want to continue to do public education. We want to try and at least train the chemist shop owners and the people who are running the chemist shops, so they'll do a good job. But yet another thing has, another potential problem has also cropped up. We have two different strengths of anti-malarial syrups in Ghana. We have artemether lumefantrine 20/120, and now there's a different one on the market. It says 180/1080, but if you actually do the math, you realize that that is 15 milligrams of artemether, 90 milligrams of lumefantrine per 5 mils. So it's a little bit weaker. The problem is that we don't know what's going on out in the chemist shops. We don't know that the dosages for these things are on the package. However, that does not ensure that somebody's going to follow the dosing properly. And in addition, I just ran into a situation on our children's ward yesterday where one of the mothers who was supposed to buy paracetamol syrup for her 6.8 kilogram infant had bought PMOL tablets. And only because I happened, God being wonderful, as the Ghanaians would say, I just happened to ask her, did she have paracetamol? And then she gleefully showed us these tablets. And I'm looking at this little baby and I'm looking at her and I'm thinking, oh heavens, what's happening? Because I'm aware that in America now, acetaminophen poisoning has become one of the major causes of liver failure for pediatric patients in America. So even this isn't an antimicrobial challenge, but this is definitely a challenge. So that's what we're doing. We're trying. Okay. Are we succeeding?
Ian, I think we're quite short of time. It's so great to see you, though. I didn't mean to interrupt you. I'm really pleased that you could join, and I hope I did justice to the presentation. Yeah. Yvonne, I'm worried about time. Are we okay for time?
I'm through with my stuff. It's fine.
No, that's fantastic. And I think going back to your partnership, the challenges you have mentioned are many and varied, but I think we would all agree, many of us would agree, that through the partnership, we've been able to address some of them in ways that we may have otherwise not have thought about, which can only be a good thing. Yvonne, back to you.
Hello, please, am I audible?
Yes, you are. Hello.
Okay. All right. Thank you very much. I dropped off for a moment, so I didn't hear the some of what Dr. Young was saying, but I think that I heard most of it, so that should do. Please, do we have any questions? If you have any questions for any of the presentations, with respect to any of the presentations, this would be a good time. You could raise your hand, and then we can have a brief session of maybe interaction, or you have a comment. There is something that you heard which you think you are taking with you. There is something you found very interesting, or something that you think could be done better, maybe a comment on or a suggestion on how some of the things we are looking to do could be done better, that would be great. This is a good time to raise your hand and make any comment or any suggestion. I do not see a hand up. Okay, all right. I was just about to say, in that case, we will listen to Mrs. Aziz, but I see that we have 3 hands up already. Mrs. Joycelyn Aziz, Chief Program Officer, will you speak first? And then we will hear, it could be your comments, which you were giving us, which we couldn't get all of because of the sound. Please go ahead and speak, or any other comments that you may have. Thank you.
Thank you very much, guys, for the break, because I was trying to give my opening remarks, okay, from all the presenters, and then have a say. First of all, I want to congratulate all the partners in this project. I think it's been very on. AMR's worship is and we are open to collaborate with all partners in this project. I think one major issue that came up is about having separate AMS committees in the various institutions. And I must say, we want to use a system strengthening approach to implement our NAP. So I would rather, instead of having systems which are difficult to manage, DTCs. So subcommittee under the DTC is far better for me than having a newly created committee. Having said that, I just want to again say that all of the things that you are doing are very open to collaboration. So share with us your experiences, share with us the data. Let's see how together we can move the implementation of our NAP forward. Thank you very much. And massive congratulations to each and every one of you. I have noted some of the key problems that you are each facing and further deliberation, so that we see how together, because this whole should be done in a holistic approach. That is, for me, that is the only way that we'll be able to make massive inroads in the implementation of our NAP. So on this note, thank you very much for the opportunity. Yvonne, over.
Thank you so much. Thank you so very much. And we are very grateful for your comments. And I am sure that after this, you will get a lot of knocks on your door, because the need for system strength, I am sure, which to utilize that better. Dr. Ankra, your hand is up. After you, Dr. Mufa will speak, and then Dr. Yevuche will also speak. Please.
Thank you very much. Mine is an observation and a request. First of all, I've observed that suddenly all of us who have this partnership are engaged in PPS, which is very good. It gives us an idea of what our antimicrobial situation is in our hospitals. I encourage everybody to keep it up and try and inculcate these things in our facilities plan, so that we can do it by ourselves instead of relying on external funding. Secondly, I would like to appeal to MOH, because I saw in the action plan, nice budgets. This should trickle down to the user levels, because we will carry out all the activities. I see budget for DTC, training and all that. I see budget for this and budget for that, but these have not trickled down. I am appealing to policymakers to ensure that the operational staff are fully supported. Thank you.
Thank you. Let's go ahead, Dr. Mufa.
So thank you very much. And earlier there was a question to me about aspects of inadequate funding that needed to be supported. I did just a brief response to that. I mean, definitely because of the limited funding, we couldn't do the community extension. In fact, we didn't even include it in the in the main proposal, even though it was part of the background extension. That definitely, if we want to do it, we'll need additional funding. I mean, to involve the community pharmacies and the community itself. The institutionalizing the delayed prescription model in a facility on a regular, ongoing manner definitely needs more funding than just an ad hoc or occasional tendency. So that is also an issue. One recommendation of concern, I mean, I definitely love the UK and the lower middle income partnerships and other things, and that will have to be sustained. But I think now capacity is being built in country, and I don't see why there can be partnership support by, I mean, in Ghana for the joint partnership submission of proposals, not necessarily including an outsider before it is funded. I am aware of the CwPAMS location, but I'm just thinking that moving forward, it will be interesting to have partnership between different facilities, organizations, and other things also in country. The last comment is what the Ankara mentioned, and I'm glad to do that because Minister of Health and others are usually very interested in coordination. Talk of coordination, but bring a report, bring this and that. I mean, that is okay. But in the NAP, it goes more than that. Resource mobilization is a major function of the ministry, and that has to trickle down, I mean, to support. If we are talking of sustainability, that cannot happen unless the ministry who is interested in making sure that systems are being built are also mobilizing additional funding to support that. And so that's my advice I'll give over.
Thank you so much. Yeah, go ahead.
Over.
Thank you. Xavier, please go ahead.
Yes, thank you very much for the opportunity. And I could see a lot of work is being done across the pilot site. I hope this is a pilot. Yes, my issue is with the LECMA. So doctor can have a listen to this. He talked about looking at the pattern of resistance and coming out with a local treatment guideline dubbed antibiotic adult, antibiotic child. Now, I wanted to find out from the team whether they saw something different that warrant a change of the choice of antibiotics, especially the first line antibiotics as recommended in standard treatment guideline for infectious diseases. If it is so, in the standard treatment guideline, there's a clause, this is a policy document, that says that for any change to be made to the standard treatment guideline, they must apply to the Minister of Health. There is a reason why this has to be done. Remember, the STG is used by health insurance in paying claims. So if you vary the game without the concern of the ministry and then the health insurance, they may end up canceling the claims or not paying for that specific claim. So there is a need to have that system followed. That if you have a trend in your hospital that you think that there's the need to change the antibiotic, and that antibiotics recommending the STG need to be changed, then you need to apply so that the minister will give it to the medicine selection committee to verify, to go through and see what can be done. It is based on this that we will see that there is the need to also review, based on other data, to review the standard treatment guideline for infectious disease. So I want to find out from them, is there any change? If there's a change, if the prescriber prescribed, would the health insurance pay for that? Would it not lead to financial loss to the hospital? And then I also want to say something.
Can I respond quickly to that? Because I think it's a misquotation of what I'm or understanding of what I said. I said the antibiotic man, antibiotic child is based on the standard treatment guidelines. I mean, the standard treatment guidelines is about how many pages? I've forgotten there, but definitely about 50 or so. But this one is a one-pager, a summary of what is presented, what is available to the prescriber. There's no change, nothing differs. If you say if you want to treat typhoid fever, the standard treatment guideline says that you have the option of A, B, C. And that is summarized in the document available to you. Locally, you know that A is resistant. I mean, the antibiotic mentioned for A in that locality is there. You have the option of the B and C. It hasn't changed anything. If you want to move to the second level line drug, according to the standard treatment guidelines, is D, F, G, and then you know the options that are available. You are not introducing Z or Q in the equation. So it's just a simplified version of the standard treatment guideline, what is summarized on one page. I mean, to assist the person instead of flipping through the documents and other things for you to do that. And the system is said that if somebody does that, where chooses something outside and it goes to the pharmacy, I mean, the pharmacy can point it out to the prescriber, and then it's sorted out. And so I think that does not mean a change. If we're introducing a Q, a P antibiotic, then definitely what you said applies, and we are cognizant of that. Over.
Thank you for the intervention.
Okay.
And the last point is, I was making a point on the chat section on the DTC and the
Yes, please, Xavier, I am ahead. Hello, please go ahead.
Good. So I was making a chart concerning Antimicrobial Stewardship Committee and DTC, and my director has spoken to that. There was a time we were evaluating the functions of DTC across the country. One of the things we found was that time for the staff to be meeting, because there are several committees. We have IPC committee, quality, we have management meeting that normally happens. So you see that the same people that are being roped into these committees. And one of the functions of DTC is to look at the antimicrobial stewardship in the hospital. So for us, we should go with the DTC and let the stewardship be a subcommittee under DTC, because neglected tropical disease team will also come and say, let us have another committee for ourselves. Non-communicable disease, NCD, may also come. So let's have one. The name is drugs and therapeutics. So it means every drug is equally important. so that they can discuss the issues well. So I think the team should look at this very well, not to form another committee. In the integrated monitoring tool that the hospital used to monitor each other, what committee they have there is DTC. I don't think there is any stewardship committee in that checklist. Over.
With what Mrs. Aziz mentioned about strengthening the existing systems and ensuring that those systems work. And so, as I mentioned, I believe that some of these issues may have arisen because of some challenges they may have had with respect to implementation. So yes, they are definitely going to make sure that they will come knocking on your doors to ensure that you give them the support that is necessary to incorporate the work of that is related to antimicrobial resistance and stewardship in the system. And so as it is now, I want to thank you, but I'll ask for Dr. Ankra to just tell us in a minute a summary of what you are going to summarize. So a minute of what you are going to say in 3 minutes so that we can just wrap it up. Dr. Ankra, if you are available, please go ahead and share with us the summaries that you have captured in 1 minute. Thank you.
Thank you very much. Well, you know, there were 5 presenters from LECMA, that's the partnership between LECMA and UK Faculty of Public Health. But before that, we had a talk from the Chief Program Officer who welcomed us to this program. Then the second was the CwPAMS group, who also talked about what is happening at their place. Then we had a third from CwPAMS Hospital. The fourth group was the UHAS Whole Teaching Hospitals with University College of London and LSHCM. And then the last group to talk was the Police Hospital, Keita Municipal Hospital, and the University of Strathclyde. In fact, basically, it looks like everybody is doing something useful. But there are a few challenges which we believe that if these rough edges could be smoothened, we'll be on a good path to having a very good antimicrobial stewardship agenda in the country. Thank you.
Thank you so much for a summary of our summary. So we will go back into the plenary, and when it gets to our time, Dr. Ankra, you will just go ahead and make the presentation. So once again, thank you all for joining us, and thank you particularly to the partnerships for the brilliant work that you have done and how you have shared them, and all the excitement with respect to moving forward. We can see that these partnerships and the achievements are going to last and going to be on for quite a while. And so I will say thank you once again, and say that I will see you all again in the plenary, and please let us do our best to ensure that the things that we have learned here contribute in the fight against antimicrobial resistance. Thank you and bye.
Thank you very much.
If everyone can just leave the room now, so if you click the bottom of the screen to leave the breakout room, you should go back to the main one, I think.
Just be careful to leave the room, not leave the meeting, that's all. See you in the plenary, guys.
Hello, is calling there? look, there's some, call him, tell him that